Hello and welcome to the AABIP podcast. On this podcast, we go one step beyond publications and guidelines to speak directly with leading experts in interventional pulmonology. This podcast will address not only fundamental topics in exciting publications, but also unconventional topics for which the evidence base isn't that robust. The views expressed on this podcast are those of the speaker and not necessarily endorsed by the AABIP. This is your host, Udit Chadha, an assistant professor at the Icahn School of Medicine at Mount Sinai. And with that, let's dive into the next episode.
Our topic for discussion today is robot versus robot. First, a disclaimer. This episode will not be addressing questions that necessarily have a high-quality evidence base, but we will be quoting the highest available evidence that there is for these questions, expert opinion. And I could think of no better expert to invite for this discussion than Dr. Kyle Hogarth. Dr. Hogarth is a professor of medicine and the director of bronchoscopy at the University of Chicago. He is also the former president of the SAB. Most importantly for me, he continues to be a great mentor. He is one of few physicians in the country to have experience with both the Auris and the intuitive robot. Thank you, Dr. Hogarth, for joining me on the podcast today.
Udit, thanks for having me.
Perfect. Do you have any conflicts of interest to disclose?
Oh, absolutely. So let me, at least pertaining to this discussion, I have several conflicts of interest in general, but pertaining to this discussion, we should make it very clear. So one, I have been a consultant for Auris, who has now, of course, been acquired by Johnson & Johnson. I've been a consultant for several years and received consulting fees in regards to the services I provided. And with those fees also was granted stock options, which then, of course, got exercised once the purchase of Auris went through with J&J. And so I have owned stock and still an active consultant. So there's that bias. I have done an animal lab with Intuitive, and so received a consulting fee for that animal lab. It was a one-time deal. I'm not an active consultant for them. And so at the beginning too, when we were talking about uses of the technologies, obviously I have a vast experience on humans using the Monarch system. Have only used the Ion system in animals, so not yet in humans.
So let's first discuss navigational capabilities. The Auris scope is comprised of an outer 6 millimeter sheath and an inner 4.2 millimeter scope. Usually once at a segmental bronchus, the sheath is locked into position and the scope is advanced into smaller peripheral airways. The system uses electromagnetic field generators and a reference centers. Biopsy tools are advanced through the 2.1 millimeter working channel. Ion robot has an outer diameter of 3.5 millimeters and a 2 millimeter working channel, and Ion does not rely on EMN, but its fiber optic shape sensing technology provides the catheter's location and shape information throughout the procedure. So, Dr. Hogarth, there are cases with the Auris robot, where we cannot reach generation 7, 8, 9. Do you think that the smaller size of the Ion scope will allow further navigation, or is the stability provided by the outer sheath of the Auris more important than the scope size?
It's a hard question to answer. Of course, we have limited data. There has been obviously a published study on the Monarch's ability to reach out further than a standard bronchoscope. Obviously, not in comparison to the other robot. I can tell you, my own personal experience. We've been able to get out much further than the statement you just made there in regards to the stuck at 6 or 7 or 8 generation airway. Typically can get out, and my own experience, and I don't want to speak for other large users within the U.S., but through personal conversations with them, we've been able to typically get out within about 1 to 2 centimeters of the pleura, and because that's the lesion we're going after. And of course, remember, I don't need to drive the scope to right in front of the lesion. Get me within 1 to 2 centimeters of it, and then, and especially depending on the size of the lesion, we'll pass instrumentation out that last remaining, short distance to the lesion, because obviously the instrumentation has the ability to go out further. rare exception where the size of the scope has mattered in the clinical use that I have, again, with the Monarch. And I say that because, of course, the scope outer diameter, and even in the Ion, is typically larger than the airways you and I are going through. But, the airways obviously have some ability to stretch and to give. And so, I will tell you indirectly, it's the fact that we're going out into these smaller airways is why my opinion about why we're seeing so little bleeding with biopsies, and partly because we think we're essentially, cutting off temporarily, of course, blood flow, much like you see blanching when you do a lavage, the pressure of the saline going in. We think we're seeing kind of the equivalent of distal blanching, if you will, from the scope, essentially compressing the airways distally.
Interesting.
Now, so the want to make one other caveat to what you were describing as far as the navigation. Yes, the core of the Monarch system is EMN based, but it's not a static central registration off of the tree. It is a ongoing re-registration at each branch point, carina, and that's where the field generator comes in. But it also does use image recognition in the sense of the virtual bronch tying into what is being seen in the actual airway. So it's a kind of a combination of the two, if you will. We talked about the Ion shape sensing system. It is definitely a very cool piece of technology. There's, I think, online some impressive videos of how it works, and again, if you've played with it on a mannequin or in an animal model, you can definitely see the ability, and it obviously then does not involve any electromagnetics. The only, I suppose, concern that I've had with the shape sensing is that if there's significant movement of the patient, then the registration you've done because of the position of the coil in relationship to itself is disrupted. Now, it has obviously some amount of a few second lag, so if your patient just moves barely, you don't have things undone. But if your patient does move significantly, you will have to re-register. Now, I don't know how often that comes up clinically. My discussion with people that are doing the ongoing clinical trial with them is it's been a non-issue, but they also have everyone obviously deeply under general anesthesia with paralytics, so that there is no movement possible. And again, whether you want to use paralytics or not, or whether that's part of your routine in bronchoscopy or not, that's I think for the individual to decide. I don't know, and people obviously from Intuitive would be able to tell you what's the lag time of movement, before the system defaults and you have to re-register. But it's really cool technology, no debate. The smaller outer diameter of the scope, their scope, I've not seen clinical evidence or anything published, but also even talking to users, that there's been any limitation to get out further. So that the kind of the notion that it needed to be smaller to get out further has not really borne out in clinical use. The double scope system, if you will, the outer sheath, the inner scope, that's definitely, in my opinion, led to some nice stability components when you take our biopsy. So the advantage that at least comes from that, from my perspective, is that we can engage, obviously, the sheath into whatever lobe and segment and even subsegment that we're wanting in, and then that gets locked, and then now you're driving the scope, and quite frequently now the scope portion of it is angled and articulated the direction you want to go, and which allows you to then have all the force that you're trying to apply when it comes to biopsying being stabilized by the fact that the outer sheath is holding in place. And I don't know if you're going to ask this, but I'll just keep rambling on and launch into it. Probably the main difference that's just obvious. I will give you my biased opinion, again coming from being a user, and then obviously with my conflict of interest as part of this, is the optics, right? So with the Monarch system, the optics remain in place. And are on the entire time. With the Ion system, when you you have optics the entire time you're driving and using the shape sensing and also your eyes to move the scope where you want to go. But when it is time to do biopsies, because there's the single port, you then take the optics out to then slide through, your whatever instrument you want to place through.
Yes.
Now, based obviously off the shape sensing and the knowledge of where the lesion is, and knowing that the things aren't moving because you've locked the robot, the argument to be made, of course, is that the instrumentation was going to go right where you tell it to go, and because you are biopsying the virtual lesion, you're going to be fine.
Yes.
And again, if you look at the recently published paper with the ion system, at least one of the initial the initial experiences out of Australia, it's quite excellent. And so there's an argument to be made based off the literature that maybe that the optics when you biopsy don't really matter. That the virtual representation is good enough. And again, I think the literature will bear out whether that is indeed true or not. In the truest sense, when all the Aura studies come out, versus obviously it will never be a direct comparison, but if there's similar outcomes, that would make at least one argument. But I'll tell you from my own personal experience, probably maybe about 70% of the time, up to 80%, the optics being in place hasn't definitively mattered. You're going after a lesion, it's pretty airway centric, and you drive out however far, and away you go, and that's fine. But the remaining times, not being able to see my instrument has been a key component. And I'll give you a perfect example. Case we just did last week, the airway, it was a small lesion. It was just at a centimeter in size. It was slightly eccentric, and it was off of a small branch that visually we actually almost missed because it was partially compressed externally to look kind of half misted, if you will. And anything that we were sliding down the scopes, we actually did this to sort of prove it to ourselves as we backed the robot up ever so slightly and just kept passing instruments out and showing that not a single one of them was engaging the airway that we wanted to have it be engaged. And because of the takeoff that it came at, getting the robot to angulate enough to get directly visually see down the airway hole was doable but challenging. And so we didn't bother. All we did, of course, because we could see the entire time, is pass the instrument out, articulate down. That allowed us to then slide the instrument out. You could feel it grip, slide or articulate the robot up, see that your instrumentation was going down the correct hole, airway obviously, and that's what then. And the first we did that with just to again keep proving it, is kind of for ourselves. Even though we knew, but we liked pictures, and so we slid the radial probe down. We didn't need it, but there it was, but only if you made sure that you articulated the robot to pass the instruments down to this odd angled airway. So I obviously I didn't put the ion robot in and then try it that way, but I am struck by that case was universally successful because of optics, and only because of optics, to be able to see and be able to pass instrumentation, biopsy after biopsy. Because then, as we would take the forceps out and then try to pass again, because we had steered our vision to be able to see that we were going down the correct hole, the biopsy instruments would pass down the wrong airway. Which, by the way, interestingly, on fluoro, we did fluoro as well. Again, I don't know if we needed it, probably didn't, but we're trying to kind of add multiple elements of visualization for our own sort of internal assessment of what other modalities can continue to add to success. Under fluoro, if you looked closely, it was obvious that you were going down the wrong airway, but it was subtle. And so I think that's the other key component, is that, again, without visualization, you would have passed the instrument down mentally going, oh, I'm in the same spot, or maybe it's ever so slightly different. The patient moved, blah blah blah. I mean, you could in theory see a situation where someone might have talked themselves into, I'm biopsying the same spot, when they clearly were not, because the two fluoroscopic images with a keen eye were obviously different. You should know you're in the wrong airway, but I don't want to speak for all users, but sometimes people are moving fast, sometimes people aren't paying that much of a close attention, etc. But you can clearly see with your eyes you were in the wrong airway. So I think the optics myself, it matters. And if nothing else, some of it has just been visually stunning to see what you can see in the periphery. And Udit, you were there for a lot of our first cases. I think one of the things that I was really struck by, and if our listeners reflect, we know that with a bronchus sign and a concentric EBUS sign, right? So, I mean, we all agree you're in the right airway, and gosh, you're in the middle of this thing. How come the yield is not 100% for all of us, no matter what technology? I don't care what technology you're using to get there. Why is it? Why is it? I mean, we all agree that eccentrics are a different beast, but you'd think concentrics, like the tumor must be invading the airway. Like, how are you not physically, literally running into it? One of the things that I've definitely seen with the Monarch, and I know others have as well, is just how rarely the tumor is actually invading the peripheral airway. It's definitely wrapping around it. It's definitely, encompassing it. You get a concentric, rebus view when you slide it out, but visually right in front of you, you don't see frequently an obvious, like, this is where the tumor is. Yeah. And so I'm right. You were in those cases with me as well. It's striking that I think one of the things that we obviously, why do we miss concentric lesions, again, with all technologies, et cetera, doesn't matter which, is because it's not actually invading the airway. And if you can't see that your instrument you've articulated enough that your instrument has penetrated the wall and literally gone through, that's how you end up having a non-diagnostic bronch in this situation, at least in my opinion. So that's the beauty of visualization.
On the same lines, could you tell us about some of your cases where you've used directional targeting of your instruments based on your point of contact with the airway wall, where you had an eccentric radial EBUS view and then it turned into concentric?
Right. So we were going after a 1 centimeter GGO. The person was not a candidate for any more resections. They'd already had several resections, but for wanting to have definitive certainty, but before radiation was done, or even the possibility of systemic TKIs, because there's a question of multiple GGOs. Again, we have to individualize the care. We needed a biopsy, even though pretty assuredly we all, including the patient, knew that this thing was going to be another adenocarcinoma. Just clinically, but we needed proof from kind of multiple different medical and or research reasons. So, regardless, whatever, let's go get some tissue. But it was eccentric, and obviously GGO, and in an area that had a prior surgery, so there's a lot of distortion of anatomy and airway and so forth. And this was, again, where visualization made a huge difference, because we got to the lesion. The EMN targeting, said it was on right on the other side of the wall. We put a radial probe down, could see an eccentric lesion there. And obviously, even though with radial probe you don't have directionality, right? You don't know what true north is. You definitely do when you see it rubbing against only one wall and not the other walls, right? And so when it's on one wall and not the other walls, you have directionality. So, we already knew it anyway, but again, it was that extra confirmation. And I think, I've taken a straw poll of many users, again, regardless of technology. When we are confident that we are where we belong in the periphery, the aggressiveness of your biopsies, if you will, is definitely up. You definitely, but when you're not sure or you're not confident, I know my sort of aggressiveness, how hard I'll, stab or pull with forceps, etc., is not the same, right? So, anyway, pass the needle out. We're pointed right at the wall where we want to poke through. Everybody has the experience of watching on an ultrasound with a central line, watching the needle not go into the vein, but instead compress the vein. And you've had the sort of physical experience of watching a needle or feeling a needle slide down the airway versus engaging a wall or engaging the lesion. So sure enough, pass the needle out. Even though I feel like I'm angled enough, we're going to go right through the wall. We're going to make a diagnosis. Yay. And I watch the needle slide down. And so, boom, right there, visualization made a big difference. More importantly, though, so all we did was articulate another millimeter laterally. Now we engaged. And so then we poked through. And on first pass, non-diagnostic, just not good material. But here's again the beauty of it. So we know we're in this area. We know we're going after something small. We also know that lesions, because they're in the lung, they move too, and that when you're biopsying, that there's always a scenario that your needle is not necessarily poking in, but more kind of pushing the lesion. Mm-hmm. So all we did was articulate another millimeter sort of upward, if you will. And given where the lesion was located, it actually was more anterior, but upward on the screen. That one was not diagnostic. So then we articulated ever so slightly more towards the right, which would have been where this lesion was located, more lateral, and then boom, diagnostic. But because you could see the 3 individual holes we made, it became clear, that, when we had non-diagnostic, we didn't biopsy the same spot, right? We made minor, and I mean minor adjustments because we're going after something small, and then boom, we nailed it. Here's where it gets interesting, of course. So we made a tiny little hole. We then passed the radio probe through, and lo and behold, nice concentric view. So now we passed forceps through and ripped out a whole bunch of tissue, and we did touch preps bedside, got tons of tissue and everything that they needed to do for all of their, studies, as far as also the research trial done, taken care of. Patient moves on and went home half an hour later after the case was over. So that right there is, the additional avenue of visualization. And look, there is a correlate to this, and I'm going to run an analogy here, and I'm, bear with me. But prior to EBIS, how did we biopsy mediastinal lymph nodes? Traditional TBNA, right? Now, bigger things were relatively easy because there was a big old subcarinal lesion or whatever. You can just almost throw the needle just about anywhere, right? But if you were going after smaller things, we all had the scenario where you pass the needle, and you had non-diagnostics. Okay, so what did you do? Slightly adjusted your scope, slightly adjusted where your needle insertion was, maybe change the angle of your needle insertion, right? And that, you got diagnostics. Why is this any different? That was easy. That was a scope in the mediastinum. You saw your hole, you saw your angle, you were getting feedback about diagnostics or not. And you made adjustments. You made real-time adjustments to your lack of diagnosis. Well, now we're just doing it on a much smaller scale out in the periphery, but it's that same concept, needling with visualization.
Yeah, that's fantastic. So next, let's discuss some complications. So we had reported a 3 to 4% pneumothorax rate with the Auris robot. But ION provides us with the distance from the near edge of the lesion and the distal edge of the lesion, and then also the distance from the pleura.
Yeah.
Do you expect fewer pneumothoraces in the PRECISE trial with ION just based on this information that you get?
I don't. I mean, and maybe it will. Maybe it will. That'd be great. If there's a 1 to 2% pneumothorax rate, that'll make me happy. But 3 to 4%. Yeah, I guess that's 100% greater, but it's still a very low acceptable pneumothorax rate. Also, given out how much further out we're all going, and of course, what's our other option? To only do a needle biopsy, which is not staging and doesn't guarantee enough tissue and has a higher pneumothorax rate. So, I think the pneumothorax rate is acceptable. I do think there's a logic that says kind of having a virtual representation of where the pleural edge is important, but the truth is, you know where your lesion is, you know the distance from your lesion to your pleura. I mean, you've studied the CAT scan. Otherwise, why are you doing the bronch? So, the system may or may not be telling me where the pleura is, but I know where it is anyway because I know my relationship of the airway to the lesion to what's around the lesion, right? And so, obviously your distance in, your approach to the lesion, so already how far out you can pass a needle, for example. I don't think they're going to show a lower pneumothorax rate, but they might, and that'll be great. And if nothing else, I think my personal bias is that the great thing about having 2 robotic bronchoscopy systems out there and 2 very large companies competing for a growing and large market is we, the end users, and more importantly, our patients, are going to only benefit from the competition that's going to drive technological innovations, right? I mean, there's going to be someone comes out with a neat idea. Well, then, if I was running a company, I'd sure as heck make sure that we had our own version of something, being incorporated into the next generation of our software or hardware because it clearly was a good idea, et cetera. And that comes back again, when we keep talking about optics. Again, my biased opinion is that even if you show me data that says the outcomes are the same with or without optics, we're a visual people, and when with us bronchoscopists, and we like looking at our screens and seeing where we're driving and what we're doing. So just having the optics, there's nothing else. There's a reassurance to it, I guess. At least again, in my opinion, biased as it is.
But just to play devil's advocate,
sure.
In one situation where I think optics could harm us is traditionally we've been handling bleeds with the otoscope by taking out the scope and introducing a therapeutic scope. But with the ion, you take your eyes out so you don't know someone's bleeding distally. So are we doing the right thing there by managing bleeds by withdrawing a scope and introducing a therapeutic scope, thereby breaking a wedge?
Yeah, I mean, I see that argument. How do you know if there's bleeding or not? Obviously you can always reinsert the optics. It's not like you take the optics out and you throw them away with the ion system. But you're raising a concern. Now, that being said, I'm sure the bleeding complications from the ion that'll come out of their study are going to be just as exceedingly low, if not, almost zero, as what we've been seeing so far with the Monarch. And I think that comes back to we're getting, obviously, airway tamponade and vessel tamponade, if you will. But, the devil's in the details, and in the end, of course, there's always individual case variation. I mean, everybody who's done peripheral bronchoscopy has had the situation where, you had whatever instrumentation. So pre-robotic days, for example, I had one case. So here's your N of one anecdote, where the extended working channel from the super dimension system was going down the correct airway, heading way out, biopsying a lesion successfully, et cetera. And you saw trace amounts of blood coming around the catheter, but the catheter was essentially tamponading the airway, right? But because it turns out to be a relatively significant enough bleed based on the vascularity of the lesion and the degree of lung disease, the whole issue of collateral ventilation, well, that same collateral ventilation also leads to collateral bleeding. And of course, blood started coming out some of the other segments. And pretty significantly. So we were able to see it. So I suppose there's a concern of not being able to see that there's, significant bleeding. And so, pulled that working channel out, took care of it. The patient was fine, obviously, but, how often does that actually occur? And this was a unique situation, don't know. I think there are things about the Monarch system that I like that for my personal use that doesn't necessarily again we'll have to see the data one versus the other. I do think that if you are somebody who's in a position to acquire a robot for your program and whichever one you're looking at, I think the stability and the visualization in the periphery, even if you have to take that visualization out, is still a nice movement forward for the field. Now, look, that being said, let's be fair. This all has to be weighed against all the other things that are going on in this field. I mean, the data that the experience and presentations that so far have been made of the fluoroscopic navigation, upgrade from for the super dimension system are quite impressive. And if you continue to see the advances that's going on with Varon, there's some, and again, I'm not even talking the percutaneous approach, but the changes that they've been making in their software and hardware are also quite impressive. And if you look at the data, with Archimedes, I mean, there's always another argument to say, why in the world are we trying to like twist and turn and roll our way through all these different airways when we could just, basically go right for the prize, which is the lesion. And, that's just what's currently available. As Udit, because you've used it at our center, the lung vision tool from Body Vision, especially with some of the latest, which you haven't seen, and I actually can't talk about, and I'm a consultant for them. The changes there, I think, are going to also provide a lot of different avenues. And again, I will come back to. There's been a lot of talk about, which one's better. We got to have studies. Let's do a study where we randomize a patient to one of 8 different systems. Personally, I think that's. I mean, with all due respect to the people that want to do that, I don't see why that's useful. One, we're all under different budgetary constraints. Maybe you work at a center that no matter how great, even if we have a study that says, Robot X is the greatest thing ever, that doesn't necessarily mean your hospital is going to buy it for you. And so there's that component of cost for all of these things. There's also the fact that we all think differently in the sense of what visual representations we want, how we think in 3-dimension or not. And so various systems help to the user compensate for that. And in the end, you the end user, if you take each one out for a test drive, if you will, you'll find a comfort level that may not even be able to be well described, tangibly, but that you prefer, this one over another. Same reason why you prefer one car over another, even though they both are going to get you from A to B. And I think that's important. And then lastly, the literature on all of this is limited by the fact that though the instrumentation is important, the end user is also important. So there are studies published, obviously, doing peripheral bronchoscopy that have yields that are lower than anywhere else that's described. And all I will throw out is that being a good bronchoscopist, maybe being the world's greatest, stentor or rigid bronchoscopist or EBIS doc or the world's greatest, laser debulker, blah, 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 it doesn't matter, doesn't automatically make you a good peripheral bronchoscopist. And to say that, one technology is better than another based off of one study, I mean, I'll give you my personal study. I have the same exact golf clubs as Tiger Woods, and my golf game sucks. So I would then draw the conclusion that clearly the problem with my golf game are my clubs, right? Which is stupid, right? It's the end user. Yes, I'm being silly and doing an extrapolation, but the technology's job, we keep talking about yield. I view that any of these technologies, get me to the lesion, give me proof that my tool is within the lesion, and leave it there. I mean, don't even get me started that one of our other barriers across all of the platforms is that our peripheral biopsy tools are still very limited and are essentially just remakes of this stuff that was built for central airways, where that was easy, right? A big bulky tumor in the middle of the airway, that's easy to hit, right? And you tear at and pull chunks out or stab with a needle or whatever. But we need better instrumentation in the periphery, and some people have definitely pursued that. And there are some good things out there that and everyone again has their own personal biases of what they like and don't like, which is how it should be. I don't understand. There seems to be like a movement towards trying to have a single. What's the best system that we would all have? We'd all use the same needle. We'd all use the same forceps. Like, I find that the goal, that if that's a goal of anybody, why? Like, why would that be our goal? Well, and here's the thing too, and this is what you and I have talked about this too. When studies get done, someone's like, well, you cherry picked your cases. You did navigation platform X, and you showed you got to the lesion 90% of the time, 85% of the time, whatever. Someone says, well, every nodule that came through clinic, did you use the system? Well, no, because there are certain patients that don't need a biopsy. And there are certain situations where you look at the airway relationship to the nodule, to where it's located and other structures, and you talk to your patient, because in the end, your job is to advocate for your patient. And maybe it's a better scenario, at least in this one person in front of you, that a transthoracic needle aspirate is the better route to go. And, if you have the Variant system and you want to do it that way, go right ahead. Or if you, from a logistics perspective, it's just easier to send them down to the interventional radiologist that you have a good relationship with, do it that way. Whatever, right? Mm-hmm. In the end, I don't care how you or anybody I work with or anybody who's listening or anyone in the world, I don't care how you get to the periphery. Just get there successfully, get there safely, and get me an answer, right? Mm-hmm.
Absolutely.
And look, if you need a robot and that you have incorporated 3 other technologies into the robot, and someone's like, wow, well, you needed 4 things to get out there. Well, whether I needed them or not, if you can get out there with a thin scope and your knowledge of the CT scan and you have 100% yield, awesome. Good for you. I mean, like, that's awesome. That's great for your patients. But this notion that we have to look at this from like some ego approach of, I got out there with just my knowledge of the CT scan. That's awesome. Good. But when we look back at where our field's been and where it's going, the innovation has come and the investment into this field has come because there's clearly been a need across the country and across the world for assistive technology so that we can get better. And, quite frequently there's a whole lot of ego in wrapped up in this of, well, I'm the best. I only need this. I can't believe some guy needs a robot in order to make a diagnosis. Or that lesion's big. Why did you even use technology? Because if you're honest with yourself, do you really have 100% yield on all the 3-centimeter lesions you've biopsied? Because I guarantee you anyone who says that is lying.
Mm-hmm. Absolutely.
I haven't published it. but they'll say it.
So as we come to the end of this discussion, let's briefly pick your brains about the future of robotic bronchoscopy. So first, let's discuss the near future. We have ongoing prospective multi-center trials with both the Auris and Intuitive robot, and there's a completed retrospective study on 165 patients that we both were a part of that is pending publication. Now, in-human direct comparisons, as you alluded to, are not going to happen. So do you foresee a head-to-head cadaveric trial with the robots, or do you not see that happen too?
Oh, I suppose there could be one. You know how the world works. I would be shocked if either company wants to pay for a study that has the potential to ever show that the competitor's better, right? Mm-hmm. And so you might get a scenario where someone somehow owns both robots and does that study. But I think in the end, as I said before, I had someone call me once and said, I think they were having a kind of mental comparison of they were going to buy a robot and they were trying to decide which. And the first thing I said to them simply was, first question to ask yourself is, do you need the robot? The second question is to understand that both are good. It's not like if you're somebody who, as and like I said, I'm clearly got a bias towards auras. But if someone told me, said, I bought the Ion, you're not going to hear me say, well, boy, did you just buy a lemon, right? And same as if they told me they just bought the new Floridav system, if they bought anything, it's, you know your needs, you know what you have. And you also know, by the way, your own skill set, and you also know what kind of time you can devote to bronchoscopy. And so maybe you don't need all of the things that are present. And look, this is the first generation of robots. We're going to keep seeing growth and development in this field. There's a lot of things to weigh into the decision, and I think people should be honest about what their needs are and what their budgetary issues are, and look closely. As far as the future, one of the things we haven't talked about today, and that's been going on now so far, the near future, is several centers have been incorporating use of the robot with cone beam technology. And, if you talk to Dr. Pritchett, who's obviously the king of cone beam and arguably the godfather of cone beam, at least in the U.S., he does, outside of studies, he does all his cone beam cases simply with a hollow catheter, and has made an argument that, if appropriate use of the augmented fluoro components of the system that he uses through Philips, he's got enough ability to get to these lesions with certainty and see tool in lesion, and he's published this as well, that he doesn't need any other form of assisted technology. And so that, he'll make an argument that don't go buy, systems X, Y, or Z to get yourself time on your cone beam system that your hospital probably already has and you just don't have access to. There's a valid argument there. But again, that may or not be applicable to certain users, right? But, and we need to see over and over because there's, so Mike in North Carolina and Chris Bodrod in Tennessee, and now Otis and Fabian at Vanderbilt, also in Tennessee, have been using cone beam. There's and the guys at Cleveland Clinic as well, and some folks at Mayo, we'll see more and more experience with it. But, is this something that we forget the ability to purchase the technology, the ability to use it and use it well? Will that be something that will also be able to be translated to everybody? Maybe. I mean, that is the potential argument of the sort of like real time acquisition of the lesion and then this overlay of the augmented fluoro so that you can see essentially what had been previously been unseeable. That is actually one of the major tenets of the entire lung vision system through body vision without needing cone beam, just using a C-arm. So, exciting times, right? I mean, how cool is it? All the things coming out of this. This is just us focusing on peripheral bronchoscopy, let alone everything else that's going on in the airways and going on in benign disease, et cetera, et cetera. So,
yeah, you sort of alluded to my next question. I mean, we all agree that we are a few years away from bronchoscopic ablation for peripheral lung nodules, making it to the mainstream. But I mean, we don't have any ideal tools for real-time confirmation of tool in the center. And cone beam is probably the best available technology for the purpose. But
yeah, arguably, yeah.
Based on what you just said, you do see a foreseeable future wherein inbuilt target mapping or augmented techniques may be able to match the accuracy of computed tomography?
Maybe. I mean, it's same point I made earlier. If there's a market for it and an unmet need and the ability to solve it from a technological perspective, then people will put the R&D money into it because they'll see that. So, here's the example. And I'm not making this up, but I'm clearly don't have data to back this up. So we've all seen the cone beam studies, we've all seen the presentations folks have given. It's impressive, and so let's assume that that's the gold standard, which probably is anyway. So okay, but maybe costs will come down and blah blah blah. But let's just say that there's just multiple places where that's not going to happen. That they either don't have a cone beam system, or if they do, they're not going to let the lowly bronchoscopist anywhere near it because that's being used by vascular or the cardiology for TAVRs or whatever. And so you say, okay, well, how can I get to the gold standard without having gold? Can I make a new gold standard through the application of fluoroscopy? Because, look, I mean, cone beam CT is a sweep, but in the end, it's just X-rays, right? And then computerized, algorithm of reproduction of it, of creating then a augmented overlay. There's already a system that's doing that, and so maybe not yet to where we see with cone beam, but then that raises the question: does it have to be as perfect as what you see on cone beam, visually, or is pretty darn good enough, or is good enough? Does it need to be better? Don't know, but I think that unmet need, because I think maybe we're not going to see cone beam everywhere, but a less expensive system is something we could potentially see everywhere. We'll see, right? Again, that's why it's so darn exciting. That's why there's so much opportunity here. And I think that can only be good for the bronchoscopy community and importantly, our patients.
Yeah, truly exciting times to be a bronchoscopist. I cannot thank you enough, Dr. Hogarth, for your time and the clinical pearls that you shared with us today.
Thanks, Udit. I appreciate it, man.
With that, we conclude an exciting episode here on the AABIP podcast. I hope you guys enjoyed listening to it as much as I enjoyed hosting it. Do also check out our website, theippodcast.com, and please do provide us with feedback and suggestions on what topic and which expert you want to hear next. Until next time, take care.